Hello and welcome to today's webinar, Improve Total Health with Social Needs and Personal Health Data. Before we get started, I'd like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few days after the call. I'd like to remind you of AHIP's antitrust statement and ask that you reference it in the Handouts tab. The antitrust statement prohibits us from discussing competitively sensitive information. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen.
Thank you, Catherine. I'm Ash Needham, and I'll be moderating today's discussion. We are very fortunate to have with us today Sagran Moodley from UnitedHealthcare and Drew Schiller from Validic. Sagran is the Senior Vice President of Clinical Data Services Management for UnitedHealthcare's Clinical Services Organization. In this role, he is responsible for clinical data acquisition for all members across UnitedHealthcare's Medicare, Medicaid, and commercial lines of business. With a mission to help people live healthier lives, United is making our health system work better for everyone. Sagran, thank you for joining us. Drew is the Chief Executive Officer and co-founder of Validic, the market leader in platform solutions for personal health data. Drew is solving foundational data and workflow challenges in healthcare, connecting data from patients' in-home clinical and consumer health devices with a provider or plan. With a mission to improve the quality of human life with technology that makes personal data actionable, Validic is helping power health and wellness programs for millions with organizations like Kaiser Permanente, Optum, and Weight Watchers. Drew, thank you for joining us.
Glad to be here.
Now that we've set the stage for who is leading today's webinar, let's talk through what we'll be discussing. Our goal today is to understand the potential that personal health data and social determinants data offer remote monitoring in health and wellness programs. How are organizations unifying these data to better inform interventions and improve analyses of populations? How can we use these data to drive decision-making improvements, to drive improvements in behavioral changes and identification of risk? And how can these data impact clinical outcomes and operational efficiency for providers, care managers, and health coaches? Drew and Sagran are here to help educate us on just that. So with that, let's begin. Drew, why don't you walk us through the power and potential of personal health data?
Absolutely. Thanks, Ash. Appreciate it. So at the outset, when I think about personal health data, there are millions of people who are using personal health devices with the desire to live longer, healthier lives every day. And these are devices from wearables on your wrist to weight scales to blood pressure monitors to glucose monitors, really anything to measure and monitor and improve our health outcomes as well as our lifestyle and fitness goals. And the challenge that we really have is that most healthcare decisions today are made without the use of personal health data, which is a particular challenge because 90% of U.S. adults use at least one personal health device or app on their phone. And people are generating all kinds of data about themselves every single day in their regular daily lives, from activity data to sleep to behavioral information, clinical in-home health data, patient-reported outcome measures, et cetera. And so really the solution that we need to come to is we need to be able to connect people with care providers through data that enables comprehensive care that can be really tailored down to the individual. This allows us to engage people with content that is relevant for them. And the data will really help drive more productive conversations between patients or the members and their care management team who are working to help keep them healthy and engaged in their healthcare. Personal health data also helps fill in the gaps with existing disease management programs. So care teams can spend less time checking in and more time helping out. So a lot of times what we see at Validic is a care management program for a specific disease state where a a large portion of the time for the care managers is actually picking up the phone and calling people just to check in and see how their numbers are looking. By connecting personal health data, for example, in a diabetes management program or a heart failure program, we can actually bring those data in proactively so you know if a patient is, how their numbers are looking, if they're engaged in the program, and if they actually need to have a call or not. So it really helps prioritize the time and increase the panel size and just become a lot more efficient. The reason why all this is ultimately important is that consumers today have a completely different expectation of personalization and interventions than they have in the past. And really, the way I like to think about this is sort of a shift from an analog world to a world of digital connected intelligence. So if we look at how other industries have kind of gone through this shift, in the music industry, we used to have records and tapes, and then that was digitized into CDs and MP3s. And now today, in a connected intelligence world, we have solutions like Spotify and Apple Music, where we can curate our own playlists. We can get push notifications about new artists that might be interesting to us. Likewise, in the retail space, we used to have mom and pop stores, and then that got digitized into, highly curated, very specific .com properties that would allow us to buy the thing that we used to go to the specialty store for, and now we could go to the specialty website. But now that's turned into an online marketplace like Amazon or eBay or Etsy, where we can really go and have a much more sort of connected intelligence decision around us. An example for me is I was looking at ordering some new floor mats for a car on Amazon, and I then went back to Amazon to order something else, and I had 3 different ads for different floor mats that were actually really relevant to me, and I ended up buying one of the ones that they recommended because it was different than the one I'd previously been looking at. So it's a really interesting sort of curated engagement strategy that Amazon offered, and they certainly take a very consumer-focused approach in how they market. In the finance space, in the analog world, we had cash and paper statements. The digitization of that was the credit card authorization with real-time authorizations. We had online statements instead of paper statements, which were really big. But now, today, we have solutions like Venmo, where I don't even have to think about what bank someone may have or how to get them money, or if someone can take my credit card or cashing a check. I can just literally send someone a payment instantly, and it's social. You can actually request money from friends. It's a much broader platform than what was previously available in the finance space. So moving into healthcare, which is now sort of following in that same path, we went from paper health records and sort of personal family doctors to now we have sort of our legacy EMR solutions that we have in place. We have a lot of portals and all of that. We have some, telephone-based doctors. But really what we're starting to see is the rise of connected intelligence in the healthcare space. And this is where health plans and leading health systems can really start to change the game in terms of how we engage consumers in their healthcare, and in the really ultimately helping to partner with them on building the quality of life that they would like to lead. That's really ultimately what this comes down to. As Ash mentioned at the top, at Validic, our mission is to improve the quality of human life by building technology that makes personal data actionable. And that's really what this boils down to. Quick personal story. I was just on the phone with my mother-in-law, my stepmother last night, and she has a particular quality of life issue right now that's been kind of impacting her for the last year. And she's really at her wit's end. She's struggling mightily to get the care that she wants. And she said, listen, all I want is my life back. And that is a sentiment that we hear time and time again from people who are in the programs that we have, people who have chronic conditions that are impacting the quality of their life. Really what they want at the end of the day is just to be able to do the things that they love to do. And what I want to talk about here are a couple of programs that Validic has been able to be a part of that have really helped to improve the quality of people's lives, and that's led to real ROI and just bottom line good healthcare business for our clients. So the first example is with OnLife, and OnLife Health has taken, they're a division of GuideWell, and they've really taken a hyper-personalization approach to health and wellness engagement. And specifically, one of the first things they did through their partnership with Validic was they enabled a bring your own device approach to the kinds of data that you can capture in your daily lives and bring into the OnLife platform. And that bring your own device strategy actually led immediately to a 23.7% increase in new member engagement. And what that means is that before they kind of had one device that they offered on a somewhat basic platform, they expanded that out to be able to include a lot of different device types and some new incentive models, and they showed an immediate increase in engagement from their members when they joined the program. The second thing that they did was they started to look at the number or the amount of physical activity that people were actually having on their program, in their wellness program. And they looked at, 10,000 steps a day is something that they had been incentivizing people to. A lot of companies and organizations had been using this 10,000 step magical number. And what they found was that for sedentary members in their program, and they define that as by people who are walking fewer than 2,500 steps a day, getting them to 10,000 steps a day, you might as well have asked them to climb a mountain. It was just not going to be possible, or at least not right away. And so instead, what they did was they encouraged these members who were walking, about 2,500 steps a day, just to increase their activity slightly and moderately and incrementally, and then worked them toward incentivizing them to walk 5,000 steps. And the result was that for the population of folks who were able to move more and increase their average step count to 5,000 steps, that group that increased their step count saw an average claims reduction of about $480 per year per member versus the sedentary population. And then similarly, they took members who had been averaging about 5,000 steps and asked them, instead of 10,000, asked them to increase their activity moderately to 7,500 steps. So it's, a 50% increase. And those members actually, once they increased their steps, they saw an average of about $800 a year of claim savings over the sedentary population. So it's a really good example of how if you can just help people improve the quality metrics incrementally, they can actually have really big benefits both to their quality of life and also to the bottom line of the health plan. The second example that I want to use is of Kaiser Permanente. And within Kaiser, Validic is powering a remote patient monitoring program that's deployed across 6 regions of Kaiser. It's actually deployed in their Epic clinical workflow with over 26,000 members who are actively engaged. And that program supports primarily diabetes and hypertension programs. And of the 26,000 that are actively engaged, there's actually over 45,000 enrolled. So it's a fairly high engagement number versus the number that are actually enrolled. So it's a sizable program. Of note, the members with diabetes who are being monitored for diabetes have seen their average A1C drop by a point. 80% of the physicians who have been surveyed with members enrolled in the program say that the program saves them time. So it's a new technology program rolled out in the physician's clinical workflow, and they actually say that it saves them time, which we feel like was a big win. And the members in the program themselves actually report very, very high satisfaction scores. They have a net promoter score for the members enrolled in the program of 54. Which, I don't know, if you look at the normalized net promoter score, it's 76. So it's a very, very high patient satisfaction score. And then finally, I want to talk about a couple of regulatory changes that are really exciting in the personal health data space, just to sort of set the tone for kind of what's happening in the broader landscape. In 2018, CMS allowed for a remote monitoring code for reimbursement for a new CPT code for reimbursement for remote monitoring. That particular code was just physician time, and it was 30 minutes of reviewing remotely captured data from a medical device. In 2019, CMS actually released 3 new remote monitoring codes based on the success of the code they released in 2018. And these are shown here on the display. And basically, the short of it is that 99453 and 99454 can reimburse for setting up technologies and delivery of the transmission of the remote monitoring data. And then 99457 covers time spent by a qualified medical professional for reviewing and utilizing the physiological data. And so that can be a physician or somebody who is working in coordination with the physician. And this really provides an opportunity for payers and providers to see financial support for their RPM services from CMS, and it really is starting to lead the way to how we can leverage remote monitoring across all of the CMS programs, including MA plans. And what we're really excited about in the remote monitoring space, in addition to the expansion of these codes, is that beginning in 2020, CMS has stated that this code set will be available for billing by home health agencies, which is a really excellent opportunity given the number of home health nurses there are out there who are currently either physically visiting or calling on people who have chronic conditions, or trying to manage multiple chronic conditions, especially those in the Medicare space. So with that, I'll take a step back and let Sagran talk about social determinants, and look forward to the conversation here in a little bit.
Thank you, Drew. Really appreciate you walking us through the overview of personal health data and helping us understand through the digitization across industries where healthcare is headed. Sagran, over to you. Let's talk about the power and potential of social determinants of health.
Yeah, thank you very much. First of all, I want to thank you for the opportunity, and really social determinants, boy, as that continue to become mainstream for just everyone who's involved in healthcare, and really the complexity and challenges around solving for social determinants. I'm going to spend a little bit of time touching on some of the highlights, and I'm sure this is not a new topic for you, but allow me to share maybe another perspective if it's not something you've heard. So first of all, again, on behalf of UnitedHealth Group, I'm really delighted to be Drew and I continue to do a number of exciting things together. And Validic and their mission of really innovation and intersecting innovation with clinical opportunity to advance outcomes and really drive holistic care is really very in line with the things we want to do. In United, our mission is to help people live healthier lives and really make the healthcare system work better for everyone. And we're working across a number of very collaborative initiatives in both the private and public sector to drive modernization and transformation of care in what I call an industry-first manner. In fact, I'm in DC. I arrived this morning because I'm at the Interoperability ONC Forum. Again, because there's a lot of work to do, not just from United as an enterprise, but for us as a national agenda for advancing care and the delivery system. But when we think about it, we come down a level in United. We think of, every person has a story that we can and want to positively impact. But in order to do that, you have to shift to this whole person model, and you've heard this many times. But you can't talk about whole person model unless you define. Can you go to the next slide if you don't mind? If you don't, thank you. If you don't really define care, so and think about it and peel this layer back, and then you think about redefining care to drive to this whole person model. And for us, triple aim is kind of the true north. The AHIP triple aim. Imagine 11 years ago there was this mission around improving health outcomes, improving patient satisfaction experience, and lowering per capita cost. Well, that's still very much true. In fact, I've heard the other day that someone talked about the quadruple aim because provider engagement and NPS is important and absolutely top of mind. But we need to stay grounded with the mission of the triple aim, and then find ways to drive new value creation models with our providers and health systems, and that's pretty much a mission. But when we think of this true north, you quickly find that you'll get to the heart of social determinants and the barriers that comes with it. And so what's really on the slide is the infrastructure, so to speak, to redefining the care and the whole person and understanding what those barriers are, and then really getting to the heart of how you can improve those outcomes. We do a great job when patients are in the four walls of a clinical setting, but when they're not in the four walls of the clinical setting, especially across some of the populations we serve, you're not connected anymore. And the next time you connected is when they have an acute encounter in an emergency. So let's go to the next slide. So this is numbers, right? You've probably seen, this is the Robert Wood Johnson Foundation, the Kaiser Foundation, to name a few, but there's a lot of research and studies talk about social determinants. In fact, that 80% number at the bottom, that's kind of pegged towards health and well-being and social determinants. I read a study that said 20% of that is genetics, and 60% still comes down to social determinants. And I call it, SEFF, social, economic, familial, and functional risk that present itself. And in fact, also on the slide, you'll see a number of Medicaid states we serve require us to do screening for social needs, transportation, homelessness, to name a few. So there's a gentleman that I ran into a couple of years ago, Dr. Rishi Manchada. If you haven't looked him up, you should. Very, very exciting guy. He talks about this concept called the upstreamist. And the upstreamist is, how do you move upstream to understand what the barriers are? If it talks about the story of a woman presents with a nagging cough and upper respiratory challenges and health challenges, and only to find out that she had mold at home. And so getting upstream is really, very important. But what we find in United is, if we do want to go upstream, it's important for our clinicians to perform at the top of their license. It's not uncommon for nurses who visit our patients in their homes are solving transportation issues. And so this insurgence of community health workers have really stepped in to fill this void. And as I think about this aspect of getting outside of the four walls of a clinical setting, I call it sitting at the kitchen table, because I can picture one of our community health workers, caregivers, sitting at the kitchen table and really getting to know the unique challenges and barriers that the family face and our members face. And if healthcare is local, solving social barriers is exceptionally local and uniquely local, whether it's Meals for Wills and St. Mary's Food Bank and Visiting Angels, and community partners are really at the epicenter of being able to solve for this. In fact, when I draw this picture of social determinants on a slide, I draw the patient in the center, and the first outer band, I would draw the patient and the patient's family. Because it's easy to have the patient's daughter say, hey, can you check up on mom to make sure she's got discharged from hospital and make sure she's fine and she's recovering and eating and resting and following a discharge plan, or maybe help with a plan. And the outer band, the next band, be after the patient's family and friends, community health partners. And those health partners are very local. And then PCP, and then specialty, and hopefully you never ever have to go to the extreme of band, which is, acute care. But that's essentially the idea. So, and this bottom 20% is really interesting, because when I first started to talk to physicians, clinicians about social determinants, they were worried that addressing some of the needs fell outside of their clinical workflow. If a nurse is talking to a patient and the patient says, I'm homeless, what can the nurse do? And many centers and FQHCs and other facilities we work with will have social workers who they'll then bring in to the overall care plan and then engage them in an active way. But there's many clinicians who don't have the luxury of having additional social work or other networks of support, and so that becomes a little constraining. But 20+% of clinicians are confident and they have the ability to address it, and that'll grow and increase. So why don't we go to the next slide? So again, I'm sure there's just a couple examples that the evidence is clearly there. The one that I'm always intrigued about is we really want to, as a industry, drive better outcomes and drive improve patient experience, really lower per capita costs. We all know that healthcare spend is on a rise, and if not the highest in the world and in the United States. But this avoidable readmissions and inpatient high acute encounters is really, there's a lot of things that's been done to address social determinants, including education. We often find that diabetes in low income, high financial stress families is hard to manage because you need to eat right and you need to have better med adherence, and you need to have education. So you don't want the first time the patient to know they have diabetes when they're having a foot amputation in an emergency room. So there's a lot of evidence, and this just speaks to some of it. So if you can go forward. I like this slide a lot because this is a slide I often go to. Payers are very, very savvy with big data. We got claims, right? So claims admin data gives us a lot of data, and with a lot of data, you can run analytics. And part of United includes Optum, and Optum has a very, very strong domain around analytics, if you will. And so we have the ability to slice and dice the 6 ways from Sunday. And so you could tell that in, the average 65-year-old diabetic living in this demographic and facing these barriers will have these risks. But when we're trying to get to the patient, we need to know about Betty Smith, the 65-year-old diabetic. And Betty is unique because, yes, she's the 65-year-old diabetic, but she's a quadriplegic. She has mental health depression. She has some social barriers for transportation. She lives alone, probably has poor ADLs, low functional status with grooming and bathing and ambulating. And then she has diabetes. And so this intersection of clinical and social risk is just very, very critical. If the top 1.5% of patients drive about a third of the healthcare spend, and the top 5% drives about half, then social determinants is absolutely right. In you have to bring it into view to be able to get to that clinical and social risk. Can we go forward? This is an interesting slide. In United, this is just the number of beneficiaries we collect in social determinants on. There's a lot of numbers on here. But the number in the bottom left is maybe something I want to talk a little bit about. So as we started to do, and you've seen a lot of things in the press about United doing green work around social determinants, we've created a value model of the amount of services we've directed to these partners, and have figured out how to establish a value to it. And to date, we have created a value model of about $800 million. What does it mean? Every time we directed a member to Lyft to support transportation needs, or directed a member to one of the community partners like Nestle's Nutrition for health and nutrition needs, we've established the value of that service had you paid for it on the open market, and driving back the social value back to the market and fueling this and flourishing this market of opportunity for community partners to thrive and really start becoming very mainstream, because as I said, a lot of them are run on shoestring budgets but do God's work. And so this is just a way for us to really bring this to the forefront of the agenda and really have this as a mainstream conversation. Go to the next slide. So to really bring this all to the brass tacks of how do we change the way the industry supports social determinants? We've been very, very active in working with a number of industry partners and made a recommendation to CMS to expand the ICD-10 code set to include 23 new codes. A lot of work went into really roundtables and pay and partner leaders, thought leadership, AMA, NCQA, a lot of work, CMS listening sessions. And so the committee decision was expected in June. I think it's a little behind. But if it's approved, then in April 2020, there'll be new ICD codes. What does that mean? You could actually go and code homelessness as an ICD code. You could code transportation as an ICD code. Lack of, right? So this is really important as we think about bringing it into the, because gathering social determinant data, I represent clinical data services for United and the responsibility to bring clinical data for over 50 million lives across a broad array of clinical settings. And while we get clinical care continuity documents and ORUs and labs and admits and discharge notices from a broad array and spectrum of providers and healthcare partners and system providers, social determinants needs to be codified to really bring that forward. Let's go to the next slide. So, this is the lady, Schiller Shapiro. If you have any questions following this presentation, feel free to reach out to her. She's a partner of mine. We are in the same business unit and work very closely. She is just very dynamic in the way she thinks about this problem space. She has a good leadership team that supports her and works with her and across not just United, but many other partners. So thank you very much for the opportunity, and I look forward to any questions and answers when we get to it. Back to you.
Thank you, Sagran, for sharing your perspective on social determinants of health and for really detailing how United is advancing care with these data, particularly on creating new models that are driven at value. So let's jump straight into the panel discussion. So you both talked about how these data are being leveraged in healthcare services and programs to provide a better understanding of the individual. Where do you see the present opportunities for personal health and social determinant data? Drew, let's start with you.
Yeah, all right. Thanks so much. So, and Sagran, thanks for that social determinants overview. That was really good information. You know, I think when I think about how do we, or what are the opportunities presented for these data, I think it's really important for us in the healthcare industry to think about the full picture of an individual's health. And so if you think about, there are, popularized by REMS, there are 525,600 minutes in a year. And yet the average person spends less than 30 minutes of face-to-face time with a healthcare professional. That's a lot of time that's being spent living our lives day to day. And there are data that we're creating that whether it's passively or actively about our lives that can help show those of us in healthcare what is happening and under what circumstances that allow for sort of a more tailored intervention than what we've historically given. So one really quick story on this is that a gentleman by the name of Steve, who I've gotten to know through one of our programs, he is living with type 2 diabetes, and for over a decade, he was living with uncontrolled type 2 diabetes. And it was not that he wasn't trying to control it. He was seeing an endocrinologist regularly. He had a glucose meter. He was taking quarterly A1C readings, and he was really trying to do the things that he could do to control this. But, to Sagran's point earlier, where, there's access to food challenges. There's also, for Steve, it was more of a food education challenge. And the reason why I say it is that when Steve ultimately got enrolled in a program that brought the data from his glucose monitor, as well as a weight scale and a nutrition app and a activity tracker into his clinical workflow for care management team in a program of care that was designed around bringing in all of the lifestyle information about Steve, they started to look at his data. And after a couple weeks in the program, one of the care managers reached out to Steve and said, hey, help us understand, what's happening in your life between 7 and 9 p.m. at night, because you're not logging any new foods, but your glucose is spiking before you go to bed every night. And Steve said, oh, nothing's happening. My wife and my kids are in college. My wife and I are rediscovering our new lives. And so we're watching Netflix and we're eating some popcorn and that's it. And the care manager said, wait a minute, popcorn? What's that? And he said, no, it's no big deal. It's fat free. It's, there's no butter, no salt or anything like that on popcorn. It's just, it's kind of like free food, 0 calories. And of course, obviously that popcorn was metabolizing in his body as sugar, and it was throwing his numbers off. So that was really an educational opportunity for Steve, that the data really helped to bring that awareness to him. And so he stopped using popcorn, and within 30 days, his A1C, which had previously started at around 9.5, his A1C dropped to 0.5 point. And it was the first time that he had ever seen that he could make a behavioral change that would actually lead to a clinical meaningful drop in his health outcomes, or in his A1C readings specifically. And so from there, Steve started working with his care management team around other changes that he could make. And one of the things was that he started exercising in the morning, and he found that gave him a lot more energy. Steve had actually gotten to a point where he had previously had to quit his full-time job and go down to part-time because he didn't have enough energy to sustain the day because his diabetes was so out of control. But now he's back to being able to work a full-time day. He has more energy. He understands more about food and how it impacts his life. And he loves his life now, whereas before he had a real quality of life issue and he felt like he really couldn't control his condition. So I think that, this is really where the sort of combination of personal health and social determinants and just general behavioral data can start to really influence the care of an individual that can ultimately lead to the care of individuals across an entire program.
Yeah, and on the United side, we have Bluetooth scales for about 20,000+ congestive heart failure patients, and bring data in real time, right? So the idea is our patients use the scale, and our members, and we'll look for with both alerts, thresholds, and triggers into the patient-generated data that looks for weight deviations based on a certain threshold. And when those are triggered, then it alerts the next best clinical action, which then involves activation of a clinical team, who then will reach out and then looking up at, is there a change in the water medication because of the body fluid accumulation for this patient? And so many times when we do that, we're expanding out the capabilities in the app that they use about, if they had transportation needs, to be able to go back and see their PCP, assuming we can get it under control with just altering the meds, or trying to quickly get them back into the cardiologist. And so you really can't get to driving that next best clinical action if you don't understand those barriers, because yes, you can go schedule the appointment and we can allow our nurse to go get the appointment scheduling, but if the patient has a barrier to getting in because maybe they're wheelchair bound and they can't get in, it won't help. And so it's really becoming very important to understand how you can remove these barriers, and you're going to see more and more of that starting to come together.
Sagran, you raise a lot of great points. So, how can clinicians help here?
Yeah, no, that's a good question. Thank you. First of all, the clinicians really are at the forefront of being able to engage with patients and really understand their clinical challenges, whatever their problems are, and how they present in those settings. But then also being able to encourage patients to self-report. In fact, I shared on a prior slide, we have over 2.5 million. We have social determinants from over 2.5 million United members who self-report. And they would actually say, I do have transportation challenges. Or I do have housing challenges, and that allows us to kind of assist them. So when patients are willing and able and motivated to self-report, then we can help and provide access to the right services or community partners. There's also opportunity to document, and hopefully we're confident we'll get the expansion of ICD codes in. And when that happens, there's an opportunity for us to go and add these new ICD-10 codes to identify social barriers or social determinant issues. And then really, care coordination is the most complex. If a patient has mental health, depression, facing social barriers, being treated for diabetes by their primary care, sees a mental health psychiatrist in a behavioral health clinic for mental health, and also sees a cardiologist for this congestive heart failure, being able to communicate the social barriers across all of those clinical teams are really important, because when the mental health provider changes a patient's psych drugs, it might have ramifications on the patient's heart condition and adverse outcomes. And so communication and coordination of this across interdisciplinary teams and care teams, including social barriers. While someone thinks, well, we can get this patient to follow a very rigid diabetes plan, but they can't afford to get their medication, that presents a challenge. Or they can't afford to come in for their follow-up visit, that's a challenge. Ken, any other questions on that?
Yeah, Sagran, sorry, Ash. I was just thinking, when I think about how clinicians can help, just building on that, on what Sagran was just saying, I was thinking about how, one of the ways I think that that clinicians can help once they have access to these data is that these data can really start to change the conversation with the patients, and I think that's a really interesting opportunity. I think about my grandmother who unfortunately died via complications of COPD, and for decades she was overweight, she smoked, and for decades her physician was saying, you need to eat healthier. She's like, yeah, I get it. Like, I'm trying. you need to exercise more. She's like, yeah, I know that. You need to quit smoking. She's like, yeah, I know that. And over decades, it just became like this sort of noise that was just sort of constantly. She like knew what she was in for when she had her doctor's appointment, right? She was in for someone telling her the things that she knew she already needed to do, and she tried those things. It didn't work, and whereas now with these new data that we have available, we can actually change that sort of monologue of like the preaching clinician into more of a dialogue where, like my example that I use with Steve, where, his endocrinologist for a decade had been saying, Steve, you need to eat healthier, you need to exercise more. And he's like, I'm trying. But then once the data was available, it became, hey, what's happening, at night? What are you doing right here at this point in time? Because we see that that's the area that you're struggling in. And it became a dialogue, and that dialogue ended up unlocking insights that really helped him change his life and improve his clinical outcomes. So I think that's where, clinicians can really, once they have these data, can really start to make a meaningful impact in the daily lives of patients.
Thanks, Drew. Thanks, Sagran. So we're going to try to incorporate some of the questions coming in from the audience as well. But Drew, can you help us understand where organizations who want to utilize these data should begin?
Yes, absolutely. So I think one of the really important areas to begin is by working to develop a program of care that supports the clinical goals, so what you would like to happen with the patients, as well as the quality of life goals of the individual patients. So I think that those two things sometimes feel opposed because we'd like to lower the cost of delivering care to an individual. We'd like to have them improve their lab numbers and not develop comorbidities. And what the patient really wants is just to feel like they're in control of their lives and have a good quality of life. And I think that, oftentimes I hear when people are starting to utilize these data, I hear questions around, well, how do we engage members in these programs? Because patient engagement is a huge challenge, and and it is a huge challenge. But what we've seen is that when you start designing a program that incorporates the goals of how a person wants to live their life and the quality of life that they want to have, and marry those two things up and say, by controlling these numbers, you will feel better, you will have more energy, and incrementally make steps towards that. People will start to feel like they have control of their lives. That's exactly what they want. They'll be much more engaged. So ultimately it comes down to a program of care that clinical staff members and patients align on upfront. These are our clinical goals. This is why we're doing this. And it's not 100% of patients are going to be aligned with that. There's always going to be, call it 5% of people who are stubborn and really just want doctors to treat them and they don't want to have to do anything. But what we've experienced, for example, in the remote monitoring program with Kaiser Permanente that I mentioned earlier, is that when the physicians enroll the patient in that program of care at the outset and walk the patient through, these are the goals. When you don't record a reading, you're going to get alerted about that. If a reading comes in and it falls outside of a range that we're concerned about, we're going to get notified. It starts to help the patient feel like they're in it together with somebody, and that just the feeling that the healthcare entity has their back, and that their data is going somewhere meaningful, and they're not just collecting the data for data's sake. We feel like we generally see those programs be highly engaging and motivating for patients.
Thanks, Drew. Sagran, what are some of the other things that United is doing to advance the integration of social determinants of health into clinical programs and models? And people are sort of particularly interested in the payer-provider relationship as it relates to this.
Yeah, no, thank you for the question. And I talked a little bit about the work we're doing with CMS and industry adoption or expansion of ICD codes. We've had a number of very active conversations, discussion, thought leadership a roundtable with AMA, NCQA, AHA, come together to endorse these codes, including participating in there's a Future of Nurse in 2020 and many other conferences to really seek feedback from clinicians on the ground and really community partners as well. I also have the privilege of serving as the co-founder and chair of DaVinci, which is a private sector initiative to promote and advance interoperability, leveraging HL7 FHIR, but it's really to support value-based care. And as we think of the number of use cases under DaVinci, there's a lot of work to be done to really create quote-unquote standards that can accelerate interoperability. And if you'd asked me what interoperability was 5 years ago, I would have said it was about data exchange and data liquidity. But it's really more not just about workflow or data integration, but actually workflow integration. So we're doing a lot about, it's one thing to get these social determinant and remote patient data from patients or from other sources. It's really important to bring it back into the workflow. So when the primary care doc, if a patient has a Desker G5 diabetes device, and we collecting that information, or we collecting that information from that Bluetooth scale for a CHF patient, how can we get that data back into the PCP? Because they're responsible, or at least want to get, they might have a treatment plan. Hopefully they have a treatment plan to drive and work towards the patient's goal. So, remember, I have the opportunity to sit on the HL7 Advisory Leadership Council, which also helps to make sure these standards can evolve and emerge. So United has a lot of passion around really driving this in a very industry-first manner and working towards helping our members live healthier lives and really make the healthcare system work better.
Thank you, Sagran. And Drew, as organizations scale these remote monitoring and population health programs using these data, where do you often see them struggle?
Yeah, absolutely. So, I think building off what Sagran is saying about, a first challenge is how do you bring the data into the clinical record in a way that is meaningful. And, the great work that's being done with HL7 and DaVinci and FHIR, I think has been really transformative in making that happen. But the challenges that we see once you solve that sort of basal problem of how do you get the data into the clinical record is really how do you actually operationalize the data and bring it into the day-to-day clinical practice. How do you develop programs of care and workflows that make sense for the care teams and the clinicians in a way that is additive to their work I should say in a way that is additive to their work in terms of work experience, but not additive to their work in terms of the amount of time they need to spend on it. Because one thing that you want to be really careful about when you're bringing in new data is you don't want to add additional clinical staff burden. There's already a lot of things that they need to do that sort of fall outside of why they got into the job. So the last thing you want to do when you design these programs is add more. So one of the things that we really put a sharp focus on is how do we leverage the existing clinical workflow that the clinical staff is already utilizing, and how do you filter and alert on the data in a way that's smart, that only raises up the data when it needs to be raised up into their workflow, and otherwise allow the clinical staff to access the data at the time that makes the most sense for them. So, for example, if they want to view the data in the morning, if they want to view the data at certain intervals throughout the day, but then if there's something they really need to pay attention to, sending an alert that raises up in their clinical workflow in a way that's really meaningful. One of my favorite examples of this is oftentimes we see programs designed where, you want to know if somebody's not recording a reading because that's really important from an engagement perspective. But do you need to know that someone's not recording, for example, if someone in the diabetes or hypertension program is not recording a reading every day? Probably not. So one of the alerts that we see in our programs, most often programmed, is that if a patient does not record a reading in a 24-hour period, the patient gets a notification, whether that's a secure app message notification or an SMS to remind them that they're in the program and they need to take a reading. And every 24-hour period that they don't record a reading, they receive that message. After 7 consecutive days of not recording a reading, then an alert gets triggered that's sent into the clinical workflow for the care team to say, hey, you need to pay attention here. This person probably needs a ping. Either they're not engaged in the program, you need to understand what's happening, or maybe their device, is no longer connected and they need some help help figuring that out and getting that worked out. So it's a way of, only engaging with the clinical staff team when there's truly a problem versus other times when it might not be. And I think that overall that really helps them focus their time and effort on helping folks who really need help rather than sort of just dealing with a large influx of data and having to sift through all that information, which is just really not helpful or beneficial to anybody.
Yeah, if I could maybe add another, and thank you for that. One of the things we very, very cognizant of is alert fatigue, and device data can be very chatty lines. If you can imagine your iWatch on your phone getting your reading of your movement 24/7, and so. One of the things we've done at United is work towards this individual health record that really creates a psychology of problemless medication-less visit history. So you'd see order, refill, order, refill, and then digital data, health data, ADT data, hospital data, pharmacy data, and really create what we call a single semantic best view, because which is the latest result? Was it device 1, device 2, or device 3? Because they're going to have an overlap with some of the data they would share. And so there's a lot of work being done in this space across the enterprise at United about how to use platforms and tools like Validic and other extensions of it to really bring all of this together in a way that moves away from, to Drew's point, just providing the right data at the right time, at the right place in the care journey without creating a lot of noise in the line.
Thank you guys for that. We have time for just a brief response to one last question, and we've been getting a lot of questions specifically around the ICD-10 codes. So, Sagran, you spoke about how United is viewing the ICD-10 codes and the importance related to social determinants of health. Can you expand on why United has been at the forefront of seeking the use of these codes on behalf of the industry at large? And then there were a couple of specific questions about if these codes would officially define social determinants of health in their buckets, and then elaborating on some of the Z codes and how they're being used.
So, again, consistent with our mission around improving the healthcare system and really driving health outcomes and improving the lives of the members we serve. We believe that everybody has and should have access to much needed services, whether it's medical, behavioral, or social. And so it was very consistent with that mission that we worked very hard across the industry with key partners to help advance a common language that we can commonly use, consistently use in a standardized way to really bring or really advance the collaboration, sharing, and bidirectional exchange of this data between health delivery partners. That's the first part of your question. The second part of your question was remind me what was part 2 of your question?
Yeah, absolutely. So, there were specific questions about if these new ICD-10 codes would officially define social determinants of health and their buckets, and then specifically around some of the Z codes and then how they're being used.
Yeah, there's information that we've published with the expansion recommendation of codes that we could probably share, and it's not out there already in a public setting. I imagine it is, but the idea is these 23 codes define categories of social determinants. Housing would be a category, transportation would be a category, income assistance would be a category. So there's a number of codes that have been defined at the. These were prioritized into these high-level categories that we felt would best represent the most common barriers that we believe should need to be addressed. And in order to address it, you need to be able to qualify it.
Thank you, Sagran, and thank you both for sharing your thoughts. And thank you, everyone, for joining us today. I hope you found the conversation productive and informative. This webinar will be available on demand. You will receive an email with a link to the recording in the next 48 hours. That concludes today's webinar. Thank you again for your participation and enjoy the rest of your day.
Thank you very much for having us.